Hello, and welcome to 5-Minute Pediatric Nephrology. My name is Dr. Nephron, because anything saltier would be bad for your health. Today we are going to learn about atypical aHUS, all in about 5 minutes, but don't hold me to it. As discussed in the TMA lecture, from a classification standpoint, there's really no standardized TMA classification, what is primary, what is secondary. But here, as you can see down the flow diagram, from TMA to aHUS, we're going to be talking about atypical aHUS today. So in keeping with the theme of the TMA umbrella, atypical aHUS is an alternative complement pathway dysregulation leading to endothelial injury, TMA. It is oftentimes a trigger and genetic susceptibility model depending on the cause of atypical aHUS, which we'll talk about shortly. The epidemiology of atypical aHUS in pediatric TMA is around 10 to 30%. It occurs at any age, with different ages associated with different mutations. Chronic kidney disease is typically the result. Now, we do have treatments which have improved CKD and ESRD, but there is still significant risk. There is a high recurrence rate regardless whether the cause of the atypical aHUS was by mutation or antibodies, which we will discuss shortly. In terms of the pathogenesis, the alternative complement pathway is actually constantly active. However, you have different factors that inhibit the continuation of the complement cascade. There are also factors that amplify the cascade. Persistent activation leads to C5 activation and formation of the MAC complex, leading to endothelial injury. The difference between atypical aHUS and C3 glomerulopathy or C3 glomerulonephritis, which you may have heard of, is that atypical aHUS occurs in the solid phase. This occurs in the tissue itself, and that's why you see features of TMA with atypical aHUS, but not with C3 glomerulopathy or C3 glomerulonephritis. In terms of the causes of atypical aHUS, most commonly due to genetic mutations, so complement factor H, which again is one of those inhibitors, which we'll see in the following slide, as well as factor I and MCP, also known as CD46, followed by C3 and complement factor B, which are gain of function, so they actually allow for the continuation of the complement cascade instead of it stopping. Oftentimes, the mutation is triggered by an infection. So, for example, we discussed in the TMA lecture about aHUS and diarrhea. A patient may also have diarrhea in atypical aHUS, typically not bloody, but something to be aware of. Antibodies to factor H may also occur in slightly older children. So when we do testing, we also have to test for both genetics as well as antibodies. Here we have the pathophysiology of atypical aHUS. In the left panel, you see the fluid phase, like we said earlier, is related to C3GN, C3 glomerulopathy, but not necessarily for atypical aHUS. But as you follow this down, following my red dot, C3 to C3b, which is inhibited by factor H and factor I, which causes C3b inactivation. So when these are missing or inactive, you get persistent C3 complement cascade. If you look by step number 3, you have gain of function of factor B or C3, again leading to persistent activation and amplification of the C3 complement cascade. Here by number 2, you see autoantibodies to factor H, which prevent breakdown of C3, eventually leading to C5 to C5b to C5b to C9, this membrane attack complex, which causes cell lysis. If you look here at the bottom, eculizumab binds to C5, preventing cleavage of C5 to C5b to C9, preventing formation of this membrane attack complex, and is used in a number of complement-mediated diseases. If we look here on the right, the pathophysiology, here you have MAC formation, endothelial swelling, increased von Willebrand factor, eventually leading to arteriolar stenosis, red blood shearing, and shear-induced platelet aggregation. As we discussed, the kidney is the predominant organ that's injured, occasional neurological symptoms, and cardiac involvement in approximately 5 to 10% of cases. The clinical features of atypical aHUS present with severe AKI, in keeping with aHUS in general. There's typically no diarrheal prodrome, however there may be present as part of the infectious trigger, so don't be confused with E. coli aHUS. Remember, E. coli aHUS typically has the bloody diarrhea. Recurrent episodes are not uncommon. Hypertension and proteinuria is fairly common. Lab findings include anemia, thrombocytopenia, though not as severe as in TTP, elevated LDH, and low haptoglobin, in keeping with hemolysis, as well as schistocytes in most of the time, though they may be absent. Elevated creatinine, again significantly worse than TTP typically. C3 is oftentimes low, but not always low, so having a normal C3 does not necessarily rule out atypical aHUS. Differential diagnosis is with all the TMAs, atypical aHUS, aHUS, and TTP. Remember, in TTP you have ADAMTS13 deficiency. In aHUS you have the sugar toxin, so again, most typically has severe diarrhea, as well as bloody diarrhea. Renal involvement in the aHUS is much more severe than TTP. Neurological symptoms can be variable. Complement is typically low, but in 50%, 40 to 50% of cases it is normal, so it does not rule out atypical aHUS. And the ADAMTS13 is normal, and the treatment, again, as we mentioned, is eculizumab. Here we have a case. A 7-year-old girl presents with 3 days of fatigue, decreased urine output, and facial swelling. She had a mild upper respiratory infection a couple of weeks ago, no history of bloody diarrhea. She is hypertensive with periorbital edema. She's anemic, mildly thrombocytopenic, elevated creatinine, elevated LDH, and low haptoglobin, which are consistent with hemolysis. Peripheral smear shows schistocytes, which again is something you'd have to request. Coombs test is negative. C3 is mildly low. C4 is normal. Stool sugar toxin is negative. ADAMTS13, which again could take a little bit of time, is normal. The UA with hematuria and proteinuria. What is the treatment algorithm? So you have to rule out TTP, send an ADAMTS13, but again, you can't always wait for that test to come back, so you have to go with your clinical suspicion. The genetic testing and the antibody testing for the complement factors also take a while. So again, you must go with your clinical suspicion. Unfortunately, that means starting eculizumab early, since the earlier you treat, the better the prognosis. We discussed eculizumab blocks C5, prevents MAC formation. Early treatment prevents CKD progression and possibly some ESRD, as well as acute dialysis. Questions remain when to stop eculizumab. As we discussed, there are recurrences, and the question is, when do we stop eculizumab if we can? Diagnosis is sometimes delayed due to normal complement levels are possible, and that can make the diagnosis confusing, overlap with other diseases, and waiting for confirmatory tests. Complications, we discussed CKD 30 to 50%, acute HD is up to 50%, even with eculizumab at times. ESRD has decreased along with mortality with the introduction of eculizumab. Recurrence is common, and there is a transplant recurrent risk even after kidney transplant. Key teaching points. Complement dysregulation disease is what defines atypical aHUS. Normal C3 does not exclude the diagnosis. Eculizumab is life-saving, and early prevention prevents ESRD. And on this last slide, we have some of the references that are applicable if you'd like a deeper dive on the topic, because who wouldn't? That's your 5-minute nephrology on atypical aHUS with Dr. Nephron. Until next time, you're in good hands with renalforresidents.com. Don't forget to like, comment, and subscribe, and to stay up to date, make sure to follow us on Instagram, Renal for Residents. Take care.